Hey guys, it's Dr. Linville. Thanks for opening up this lecture. This is lecture on the post-operative hip. We're going to keep this one short and sweet. Not going to get tremendously in depth with surgical procedures here, but I do want to go over arthroscopic hip surgery and total hip arthroplasty, some basic considerations you need to know, as well as what those procedures actually are. So without further ado, let's get into it. So you can see here, I want you guys to review the anatomy of the hip. Of course I want you to do that. But to take note, particularly of the femoral neck and the acetabular rim. These are two common areas of bony overgrowth, and you'll see in later pictures in this lecture some abnormalities that are associated with the bony overgrowth, which leads to impingement and eventual labral tearing. You can also see on here the articular cartilage. Both the head of the femur has articular cartilage as well as the socket or the acetabulum. So this is common areas of damage to the chondral surfaces, which could lead to osteoarthritis over time. So just make note of those two because they'll be very important in this lecture here. Of course, I also want you to review the musculature of the hip. This is a very complex region of the body, so make sure you know it. In our palpations in lab last week, it seemed like there may have been a little confusion on insertion and origin points, so I want to make sure you guys review that and have a very good understanding of not only origin and insertion, but really of innervation as well, because a lot of these muscles share common nerves. So it's important to tease that out, especially when you're doing your myotome or dermatome testing. As we continue on, we'll start with arthroscopic surgery of the hip. So hip arthroscopy. Because of the anatomical structure of the hip, as we just mentioned, arthroscopy is a very technically demanding endeavor for surgeons. That's much different than the knee and much different than the shoulder. It's a lot of anatomy in a very confined and tight space. Appropriate patient selection is of paramount importance to a successful outcome after hip arthroscopy. The number of hip arthroscopy procedures performed in the United States by the American Board of Orthopedic Surgery candidates increased 18-fold from 1999 to 2009. And that's a huge increase in just a 10-year time span. And it's believed it's that way because of the improvements in diagnostic ability of these surgeons to see what's wrong with new imaging techniques and so on and so forth. Also, the procedure itself was very, very difficult with, as we look back, they look rudimentary at this point. The surgical tools they used back in the 90s, the advancements in technology have improved such where people who may have needed surgery back in the 90s are now getting surgery in modern day because of the advancements with surgical technique and technology that assists the surgeon. So here are some arthroscopic hip procedures, including labral repair or refixation or reconstruction, what we would call acetabuloplasties, femoroplasties, which if you hear the term plasty, it basically means a reshaping of the bone or reshaping of a structure. So as you can imagine, acetabuloplasty would be reshaping the acetabulum. Femoroplasty is reshaping the femur. Microfracture procedures and chondroplasties, those are two procedures that deal with chondral defects. There are also some weight-bearing restrictions that go along with those. Of course, there can be loose body removal if there's free-floating cartilage in the hip socket. You can also do things like synovectomies. The ligamentum teres, very important structure, sometimes gets frayed. They can debride that. And then you have your muscular and capsular procedures, as you can see listed here. So, of utmost importance is the hip labrum, and that's kind of going to be the focus of this lecture. So the hip labrum has many functions. You guys know this through your other studies in musculoskeletal too. Functions as a shock absorber, provides joint lubrication. It provides pressure distribution during weight bearing, and it aids in stability of the hip joint. The etiology of labral tears include trauma, FAI, or femoral acetabular impingement. If you have capsular laxity or hypermobility of the hip, this may be what we brought up in class the other day of micro instability over time. If you were born and have hip dysplasia, and then of course degeneration or bone-on-bone or joint space narrowing may tear the labrum. So people with labral tears present with anterior hip or groin pain and less commonly buttock pain. Frequently there are also mechanical symptoms including clicking, locking, and giving away. The most consistent physical examination finding is a positive anterior hip impingement test. This is just deep hip flexion, and it can be weight-bearing or non-weight-bearing. And I encourage you guys to review the Sutliff criteria for hip OA, because a lot of those tests would also be positive on someone who's younger that may be experiencing basically labral impingement or hip impingement. So what are some pain generators of the hip? This was a study by Tybor et al. 2008. He basically broke it down into 3 different categories, and the conditions that have the asterisk next to it are conditions that can be treated arthroscopically. So you have intra-articular, extra-articular, and hip mimickers, or basically pathologies that present around the hip. So please review these. And if you have questions, you can always shoot me an email. The hip mimickers are some of the ones that are a little more rare. And the other 2 categories, intra and extra-articular, you'll find these much, much more common. So what leads to a labral tear? Well, if we're not talking trauma, then we probably are talking, this micro instability of the labrum that occurs over time, or this repetitive progressive pinching that occurs with bony overgrowth. So we'll get into the bony overgrowth pathology here. There's 2 type of, we call them lesions that occur, but lesion may not be the correct terminology. It's more like, I've said this several times, but bony overgrowth is really the term that we would consider here due to Wolff's Law, because of consistent, repetitive leveraging and pinching of the joint. So a CAM lesion, CAM stands for Controlled Action Movement. CAM lesion is bony overgrowth of the femoral head. You have increased prevalence of this in men. And a pincer lesion is bony overgrowth on the acetabular rim, and there's an increased prevalence in women. Now, typically where a CAM lesion presents is is basically the neck of the femur, and you can see that here in this schematic or this diagram, how the head of the femur, especially near the neck, has a little extra widening compared to the one in the pincer lesion, where it's a nice smooth contoured shape here. Similarly, if we look at what a pincer lesion is, bony overgrowth of the acetabular rim, you can see it's a much thicker portion here. And what happens, this little triangle piece here in this drawing is being pinched, and this is the labrum. So this is what leads to labral tears. Now, in many people, both are present. And in that case, it's what came first, the chicken or the egg, or does it even matter? So if you have the privilege, when you work in the clinic, to see someone's x-rays, this can be used as a diagnostic tool as well for hip impingement if you see bony changes or bony abnormalities in these 2 areas. This picture is obviously looking straight down from top to bottom, superior to inferior in the patient. And I'm trying to see if there's anything else. Looks like you guys probably understand that pretty well. The pincer lesion, if you think about where impingement takes place, people feel it in the front or deep in the groin. Pincer lesions, that overgrowth of the acetabular rim, typically occurs in the anterior superior part of the acetabulum. So as far as physical therapy is concerned, what are some goals? Well, we'll go over the phase 1 goals, which usually last about the first 4 weeks post-operatively. It's all about pain control and controlling range of motion. The biggest goal here is that you want to get the glutes firing. So phase 1 goals, really for every surgery, includes tissue protection. Do not engage the repaired area. So if it's a labral repair, you want to do things that do not stress the labral repair. The labral repair can be done anterior or inferior. Typically it's anterior. So you want to avoid things like max external rotation, max hip extension, anything that would stress the anterior structures of the hip. You want to avoid those. You want to decrease pain and inflammation. You want to increase range of motion within the postoperative restrictions, and preventing muscle inhibition, of course. That's your big goal at the bottom right, to get the gluteals firing, and you want to promote muscle firing patterns, appropriate muscle firing patterns. Outpatient orthopedic setting is where you'll find these. Some surgeons have patients start about 2 weeks out, but I have worked at clinics that we start post-op day 1. You observe your patient's pain tolerance, muscle guarding, gait mechanics. They're going to be using crutches if they have a labral repair. You want to kind of determine if they're a tight person or a lax person. You can do this using the Baton Index. This may help drive your treatment priorities. If you have someone, a male, for instance, that is extremely tight, you're going to work on flexibility early on so that he has a better outcome long term. Meanwhile, if you have, the prototypical 16 to 20-year-old female who has high laxity, you're going to work a lot on stabilization, not only core but hip as well, and quadriceps too. So you want to make sure that you understand the dynamics of the individual you're working with. So patient education, you want to educate them on their weight-bearing status. So there's a slide, I think maybe it's the next slide, that goes over weight-bearing postoperatively for different procedures of the hip. Do not elevate the leg. Flat is the best. So if someone's laying supine that just had arthroscopic hip surgery and they have their leg elevated continuously throughout the day, they may develop a hip flexion contracture, and this is really hard to stretch out over time. So really what we do is we encourage our patients to try to accumulate 2 hours of prone positioning a day so that it prevents hip flexor contractures. You want to avoid, in the first 4 weeks, straight leg raises into flexion. Now, this is a very common intervention that is done for a lot of pathologies, a lot of postoperative surgeries of the lower extremity. Let's get the quad and hip firing. Let's do straight leg raises. But why do you think you would not want to do it with a post-op arthroscopic hip patient? Well, there's many reasons, but we know preoperatively that they have impingement when they go into hip flexion. Hopefully, surgery has eliminated that structural abnormality so that now they have free moving hip flexion without impingement. But you have to understand the structures that were causing impingement prior to the surgery are still inflamed and irritated because of the surgery itself. Not only that, the psoas and the iliacus, really the iliopsoas, I guess you can combine them, as well as other hip flexor musculature, actually has to cross the anterior portion of the femoral acetabular joint. And if the patient has a labral repair in the front and they continuously go into hip flexion, you can develop some acute tendinitis where the posterior surface of those tendons can almost like get sucked into the joint and cause joint-sided fraying and irritation. So you just want to be careful with how much hip flexion your patients are performing after these procedures. This goes directly opposite of our goal on the last slide that said get the glutes firing, right? If we think reciprocal muscle groups, you want to strengthen the posterior chain. They've probably been anterior chain dominant, which led to this condition. So let's get the posterior chain moving. And then range of motion restrictions, that's also going to be on our slide coming up here. So here's the precaution slide. This is a good one to memorize, especially for the test. So labral repairs, you're going to be weight bearing, toe touch weight bearing for 3 to 4 weeks. That means they're going to have crutches. Typically the people that have this procedure done are younger in age and can actually maneuver with crutches. So toe touch weight bearing for 3 to 4 weeks, unless otherwise specified by the surgeon. Range of motion for just a labral repair, you're going to keep them 0 to 90. You're going to limit external rotation to 30 degrees and limit abduction to 30 degrees as well. Remember, this is during the first phase of rehab, which is anywhere from 4 to 6 weeks, but most of these are showing you 4 weeks progression. The microfracture, which is next, is a little different because the standard of care, no matter where this is performed in the lower extremity, whether it's the ankle, the knee, or the hip, is non-weight bearing for 6 weeks to allow the procedure to take hold. And I want you guys to review the post-operative knee, or try to go on YouTube and see a video of a microfracture surgery, and you'll understand why this is. They basically make divots into the cartilage to promote blood flow, which over time will create this fibrin clot, which fills in the chondral deficit, which basically recreates the cartilage. It's almost like if you think of pothole on a road, them coming in and putting new concrete or asphalt rather inside of that. It's not as structurally sound as the original layer of asphalt, but cars can still go over it. So that's a similar concept to microfracture in the cartilage that's created following the procedure. So you again want to have the same range of motion precautions here, just the big difference is non-weight bearing. Osteoplasties, so as we talked about before, acetabuloplasties and femoroplasties, these, if there's no labral repair with this, they can be partial weight bearing for 0 to 4 weeks, and really around that 2-week mark you can start weaning them off the crutches. But these are what we would call the rim trim, and the femoroplasty is basically shaving down the abnormal bone growth from the cam lesion, and the rim trim is doing the same thing for the pincer lesion, which is also known as the acetabuloplasty. Same range of motion restrictions. Now the one that's going to be big with the range of motion restrictions is the capsular repair. So the femoroacetabular joint is encased in a very, very strong capsule. If you review the anatomy, you can see the density of the ligaments that surround it and make up this joint capsule. So when this is repaired, we want to make sure that those heal appropriately. And repairing just means that if there's a tear in the capsule, they essentially suture or sew it back together, trying to create anatomical normalcy. So you want to make sure you don't stress that. So there's very limited, no external rotation, no extension, because typically these occur in the anterior part of the capsule, and then flexion 0 to 90 degrees. So what are some intervention ideas for the arthroscopic hip? Well, day one, get them gait training, educate them on weight-bearing status, start your isometrics. We can do gluteal, quad, and transverse abdominis isometrics. You can also do hamstrings as well. You can get them on the upright bike. You just want to make sure you abide by the range of motion restrictions. And then usually they're accompanied to their first visit by a caregiver or a spouse or a family member. So you want to try to teach them manual circumduction of the hip. So we want that thing to stay moving and stay lubricated in a safe way. So during phase one, you can do prone, supine, and sideline gluteal exercises, upright bike, manual therapy. This includes posterior and inferior joint mobilizations. You can do light long axis traction or distraction and circumduction. There's tons of other things you can do. Didn't even go into soft tissue work, but things to make your patient have decreased pain are all good viable options. Just want to make sure you abide by the post-operative precautions. Here's a slide that just gives you a very basic rundown of some ideas for interventions. Very simple stuff here. So as you can see the picture at the top left, someone's giving manual circumduction to the hip. If you look from left to right, you can see I've written out what each exercise is, and you can research these. I'm sure you guys have gone over these in your class for therapeutic interventions. The picture at the bottom right of the gentleman in the red shirt doing kind of this inferior glide on this person's leg, I think would be too aggressive in phase 1 of rehabilitation, but I wanted to put a joint mobilization picture in there. What would be more appropriate is the hook lying one, where you wrap your hand around and through the person's leg and provide light joint mobilizations that way. We can review that in class if you guys are unclear on that. So this would be a good time to pause and then take some notes on the previous section and shoot me an email if there's anything that's unclear. So if you've done that, now we'll go into total hip arthroplasty. Again, this is going to be a basic overview. I want to make sure that you guys understand how to be safe with these patients and understand the post-operative restrictions and maybe some basics into the surgical procedure. So surgical indications and considerations for these patients. Total hip is used to correct irretractable damage resulting from OA, RA, or AVN. So these are the main three. There's 3 big dogs of hip arthroplasty. There's many others, and I'll let you guys see the next slide. You can also pause it on that and review it. But for the purposes of this lecture and class, I want you guys to think that OA, RA, and avascular necrosis are the big 3. The lifespan of a total hip joint replacement is less than 20 years. Candidates are usually chosen if they're 60 years or older. If they're younger patients, it's only if pain and dysfunction becomes intolerable, meaning they become bedridden or that sort of thing. Younger patients may require a revision surgery later in life, which just means that in time the components will wear down and they'll have to have new components put in. So you really want to avoid this surgery, just like a total knee, as long as humanly possible, so that you don't have to undergo 2 surgeries within a span of 15, 20 years. And, anytime we can avoid surgery is a good thing. So make sure you try to educate your patients to hold off as long as possible, and also hopefully you can help them do that. So here's that slide we talked about before. Again, you can pause it here. This is a breakdown from MSK et al. 2005. They go over a lot of stuff here. So I want you guys to know the ones we talked about before: OA, RA, and avascular necrosis. Just know this, that if you've had any sort of hip problem in the past, it may catch up to you later in life and cause, just like the knee or just like the ankle, trauma can lead to post-traumatic arthritis and not a good thing. If you look at avascular necrosis, I do want to bring up one thing here, and there's, two rather. There's idiopathic avascular necrosis, so they don't understand why this might happen in some people. But then also at the bottom is alcoholism. This is a big one. Alcoholism can actually decrease blood flow, over time for some reason to the hip joint, and lead to, this avascular necrosis of the femoral head, which then would call for a total hip. These are typically your younger patients that may have trouble with alcohol, that end up maybe in their late 40s, early 50s, that have a total hip. And then, they actually do very well after the hip procedure because they're still young and typically move okay. So outcomes after a total hip. Total hip arthroplasty predictably improves function and reduces pain in virtually all patients with disabling disease, which is a very good thing. Patient satisfaction scores regarding pain relief and improvement in function are as high as 98% at 2-year follow-up. So that's a really cool stat. It also just shows you how miserable they may have been prior to their surgery, where that at 2-year follow-up they're still very, very happy. And long-term survivability, so in a study by Hicks et al., this is way back in 1988, they looked at 87.3% to 96.5% showed survivability at 15 years with their hip arthroplasty. So what do they do? Two surgical techniques are widely used. One's the posterior approach and one's the anterior approach. And they do have their own surgical postoperative precautions. Here's what the incision sites typically look like, or where they are anatomically speaking. So the summary of the posterior approach, there's a couple things I want you to note here. If you look at the second bullet down, the capsule and short external rotators are released during the surgery, later repaired. So these are like your muscles, like the gemelli and those short external rotators. Those are taken down and repaired later. The big one here is the precaution. This is the one you guys should know very well. Hip flexion greater than 90 degrees, adduction past midline, and hip internal rotation must be avoided. These all place stress on the posterior portion of the capsule and may lead to dislocation of the hip, especially early on if these precautions are not followed. It's very hard still to dislocate a total hip. Really what you need is all three of these in combination, and you need some sort of violent event to take place. Like the person bent down too fast, they squatted down to get something, or they may have fallen onto their knee, which provides a posterior directed force through the back of the hip. But we still want to make sure that the patients understand this. And even though that typically a hip dislocation would occur with all of these three happening in conjunction with each other, do not test your limit early on with these patients in doing some of these things in isolation. Do not do these. So in the anterior approach, they actually spare those short external rotators. This avoids the need for post-op abduction pillow because adduction is not a precaution. It allows the patient greater freedom of movement in the early postoperative period. And with all that said, there are some tissues that are violated during the surgery, and these are actually ones that I might consider and care about more, right? The glute med, the glute mid, your TFL, the vastus lateralis, and the iliopsoas tendon. So you think these are like the big guns of the hip. Especially in rehab, we work these muscles a lot, so something to consider with the anterior approach. Now the anterior approach, there are precautions. Some surgeons will tell you there's no precautions, but we think back to like the shoulder with the labral repair, especially an anterior labral repair. You want to avoid max external rotation, max horizontal abduction, and extension must be avoided postoperatively. Now, you're going to want to try to regain about 10 degrees of extension for normalizing gait, but you don't want to keep having them do like a therapeutic exercise that would try to get them to maximal extension. Neutral to 10 degrees is okay. Now, usually with the anterior approach, younger patients have this done because it allows them a little more mobility immediately after surgery. Also, they can do a minimally invasive approach here, where instead of like taking down the muscles, they actually split them parallel to the muscle fibers, so it's an easy repair later. Here's what a hip replacement may look like. A couple decades ago, and they still do this sparingly, they'll do a hemiarthroplasty where they just replace the femoral head and they leave the acetabulum in place. But really the total hip replacement or total hip arthroplasty is the standard of care now, where they replace both for better fit of the joints. You can see how the stem goes down the shaft of the femur and how the acetabulum is actually replaced by metal and plastic components. So what are the physical therapy considerations here? Well, first you have to know the approach, right? You have to know the precautions of range of motion. In the initial evaluation, you're going to use standard contact precautions. You want to inspect the incision site. You're going to have staples running down their lateral leg. You want to make sure there's no infection. Put the patient through the Wells criteria for DVT. You want to check the height of their front wheel walker or their cane. And it's going to be kind of a limited evaluation secondary to the precautions. But I want you to think to yourself, what can you check? You guys have been through evaluations of almost all of the body now. I want you to think about if a patient came in that was very restricted in their range of motion, what other things could you check, not violating those postoperative precautions? So again, how does this approach, or the approach that they have, change your evaluation and rehabilitation, especially early on? So another table here, we're going to look at the approach, whether it's posterior or anterior, and this gives you a nice diagram of what your precautions are. So goals following a total hip: you want to allow soft tissue healing, reduce pain, inflammation, and swelling, increase motor control and strength, increase their independence with mobility. You want to educate the patient regarding dislocation and weight-bearing precautions, and these patients are generally weight-bearing is tolerated to full weight-bearing with an assistive device unless otherwise indicated by the surgeon. Now, when that changes is typically during a revision or a complex concomitant procedure, maybe done with a total hip, then you might limit weight-bearing. So for further information, we're going to do a shameless plug here. This goes for all the surgeries we've kind of covered, and really all the joints and the musculoskeletal and orthopedic track. There's going to be an elective that's going to be available to you that I teach, orthopedic postoperative considerations. We will go extremely in depth in these and other surgical procedures of the hip, not only the surgical procedures, but also what a postoperative rehabilitation program looks like from day one post-op to discharge. This is going to be from everything from the shoulder all the way through the spine and through the lower extremities and everything in between. So please look out for that, and I encourage you guys to take that next course if you're thinking about going into orthopedics. So with that, if you guys have any questions, you can email me. I have 3 emails. Please feel free to reach out to any of them. I'll try to answer you guys as soon as we can. So thank you guys, and I'll see you in class.